I want to thank all the members of our panel. And in the spirit of collaboration and the spirit of sisterhood, we are now going to pivot and have a slightly longer question and answer where we will collaborate with Dr. Tucker Edmonds and all the panel members from panel 1 and panel 2. We have permission to move into some of our lunch break, although I understand some people may have other conflicts. We'll go at least for the first 15 minutes or so. We'll continue the tape. And I just thought I would start off with one question, and then maybe we will alternate because there's such richness in all of your presentations. So here's the question that we would like to share with you. How might some of the interventions and approaches that we have been talking about at the national level, at the state level, be scaled up? So what would be some of your advice? What would be some of your suggestions for how to go from the oasis that many of you have created into a larger movement?
I can comment on one thing.
Please.
So this is Anne, and this is from thinking about how to create actionable strategies. I would say we're really focused on how do we take all this momentum, all of this good knowledge, and move it into actionable strategies that we can implement with our state, with all of our birthing hospitals. But then we're doing a lot of sharing with other states on figuring out how do we move to actionable strategies. We're also working to think about how do we then take the levers, the things that we can't do by just implementation, and how do we think about policy change that might wrap around to support that work. So in Illinois, Kiva mentioned the Birth Equity Initiative. We're starting this summer. We already have 76 hospitals enrolled, which are really excited because the rosters aren't due yet, but we've had a lot of press and a lot of excitement about it in Illinois. So we're going to be working on 4 key drivers. We'll be working on universal social determinants of health screening. We've talked a lot about that over the last 2 days. We're going to be asking all hospitals to review their maternal health quality data by race, ethnicity, and insurance status, and then look at disparities and look for local opportunities for improvement. We're really working on engaging patients and communities in the quality improvement work, and also thinking about how do we promote respectful care, patient-centered respectful care practices, what patients can expect, and then do patient-reported experience measures on the backside so that we can talk to every patient, find out what's happening, and get that feedback back to patients. We're going to be focusing on postpartum safety and helping patients go home with those early maternal warning signs we heard about yesterday, and really thinking about making sure patients know where to call and have a 2-week postpartum follow-up visit before they go home. And then finally, we're really focused on the work that as Flint was just talking about around implicit bias training, and really figuring out how to do a multi-leveled approach so that we can get all hospitals to participate and really get started on this journey. So those are the 4 things we're going to be working on. And then we're working to really figure out how that's going to work in Illinois, and then learn from other hospitals, other states who are doing this work. So I'm hoping those kind of actionable strategies, we'll see how that works with the hospitals that we're starting with this summer, and we'll be in constant learning mode.
Thanks a lot. Charlene, do you want to add on at this moment, and then we'll have Ms. Henderson?
What I would suggest is accountability, and especially at the payer level. In Mississippi, when we started our PQC, it was voluntary. We had free resources, we had free trainings, and people who opt out will opt out, and they tend to serve the most, the communities who need the most, and they tend to be the ones with the worst outcomes. And really, you can't accept or tolerate non-participation, especially when we're having the outcomes that we see. So when in our state Blue Cross Blue Shield really stepped up and made participation in our quality collaborative required for all of their in-hospital or in-network hospitals. And that's where we really saw the engagement, because of the there wasn't even a threat of tying it to payment, but just the possibility of it made hospital CEOs get involved, and our team really started to step up. So on some levels, you need everyone to be aligned on what quality is and hold everyone accountable to those outcomes, including equity. So we need to establish a plan if there is not equity and if there are poor outcomes, and then hold teams and hospitals to that if it's not met. And that can really come from payers at large really allow that to happen in a universal way. And otherwise, it's like state policy or state laws. But without those, when it's voluntary, we're going to see the trickling effect that we have across many of our states.
Thank you. And Ms. Henderson?
Yes. So I follow what Dr. Collier is saying. I know part of the issues around the work around equity and improving having equitable outcomes is the issue around accountability. And she mentioned that. And part of that accountability is around transparency with data. So some of these efforts, including convincing and cajoling hospitals to start stratifying data by race, ethnicity, there's going to be a need to have some accountability with sharing that data so people can see and transparently know, what's happening, where should I go? Where should I choose to get my care? And I think there's going to be a lot of resistance to that. But as we promote community engagement, they're going to demand it. They're going to demand transparency, especially as we are collecting data actively to inform these improvement efforts. And there's going to be some way that we need to be transparent with that data. The other piece that I just wanted to share is the importance of including the patient voice in this process. And I think more people are getting it, and the importance of having not just, one sole patient representative, but having, a team of educated and well-informed patients who can share their patient experience, but really that can give input to the quality improvement process. And I'd like to applaud state PQCs for the efforts that they've made for engaging patients and having their input, and using that as the next step for engaging communities.
And just to be fair, we would love to have Ms. Flint discuss how your experiences in California can be scaled up.
Yeah, I mean, California is pretty big, so it's pretty on scale. But I will say that our biggest thing is redefining what success looks like. We have the conversation so often is, well, if our average is low, our folks are barely making it, then that's fine, and that's not. Right. If there is a space where Black women are dying or Black birthing people are dying at higher rates, that's not successful. And we need to be digging deep into that piece. The same with infants, the same with some of the other pieces. We know that delayed care is one of the biggest reasons that people die in California. And we know that is a direct link to discrimination. And so in our conversations that we are constantly having is, how do we define success? And we don't define it by the top, but how we lift up the folks who are closest to the pain, not to quote my favorite, Ayanna Presley, but how do we get those folks together and look at the floor is that everybody has a joyous, thriving birth. And that we get up from there. And that's the conversation that I think we need to be having nationally. I think also we need to be thinking about, how do we diversify who we think are experts in the conversation? So often in our state, we are fighting against folks who are entrenched in ways that we used to do the same type of things, and we've been doing it this way, so why should we change? And I think diversifying the people that we have who can add their expertise, their real life experience to the work would be super helpful in us redefining what success means.
And just to go along with what Ms. Flint was saying, I think also diversifying our healthcare workforce as well. So it's diversifying the voices who are helping to make policy and do the work, like we were talking about in California, but then also really thinking about, from a policy perspective, what do we need to do to think about, how do we get more patient navigators? How do we get more doulas? How do we get more breastfeeding peer counselors? How do we get more midwives? How do we get more providers and nurses who are of color? What do we need to do from the pipeline? How do we need to have policies in place that are gonna get doulas and breastfeeding peer counselors where the patients are that need them? So I think a lot of states are looking at that right now. There's a lot of interest in figuring out what legislation would be helpful, what rules and regs, like how do you reimburse for doula care appropriately? How do you reimburse for a breastfeeding peer counselor appropriately? How do we diversify our health services? And And we know there was just an article in the New York Times this weekend showing improved health, well, it was improved, patients made improved preventative health decisions when they randomized between seeing a Black physician and a physician who was not a physician of color, and they found improved health outcomes. It was really about looking at patient decision-making around preventative healthcare. It was really striking. The differences were not subtle. And I think we continue to add the data that diversifying our health care teams are really important. And so I think as we do this work, thinking about policies that diversify our healthcare teams, but also think about those lay health workers who can be brought in, and how do we do that effectively at the state and national level. I also think another area that needs to be continued to focus on is that postpartum period. All of our maternal mortality review committee data that Charlene was talking about and others have talked about show a really significant gap in our healthcare. When you look at some of the work Dr. Zeffron from the Commonwealth Fund wrote about our differences between the US and other countries, that postpartum period really stands out, where other countries have regular home health visits, regular multiple postpartum visits, lots of using doulas and nurses and midwives to go into people's homes and provide care, and lots of increased care during the postpartum period. And the US just historically, that's been the time we haven't cared for women. All the care focus switches to the baby. And so I think really readdressing that postpartum period is another space that I think we have to continue to laser focus on.
Really outstanding comments from all of you. Thank you so much for sharing your thoughts on that question. And clearly, I think I think we've got a group of experts where everyone's got something to contribute for these questions that we have to put before you. I'm just going to dovetail on where Dr. Borders was leaving off with regards to this issue around collaboration. I mean, you kind of were challenging us just now to think more expansively, frankly, about kind of who the care team entails, who the care team involves, and who that is. And even yesterday, in a talk I was giving, I was thinking about what does it look like to have more integrated kind of models of care. And so I'd love if you all could comment on barriers, but frankly, if you know of facilitators, which sometimes is just two sides of the same coin, but oftentimes it's harder for our imagination to go to that space. It's easier to kind of think about what keeps us from being able to move forward. But if you could think about, or if you could share your experience with barriers or facilitators to really promoting collaboration among sort of the key players in the spaces that you're working in.
I would just make a comment around how our providers are educated in this country. We're not really exposed to the other members of the team until we're actually out of our training and in the workforce largely. I mean, there's for example, some obstetric and gynecology programs that offer exposure to midwifery training and vice versa, but really it's very limited. And so because of our limited exposure and knowledge about other professionals in this area, we tend to be very guarded around, your particular group. And I think it would be a huge advantage, a facilitator for additional exposure during training to different members of this maternity care team.
Right, I definitely agree. I mean, as I mentioned, we have a state with one of the lowest presence of midwifery care, and it's evident in our highest C-section rate, and it's driving a lot of the poor outcomes that we have. And there's a real scarcity mindset that we can't have more, even though we're desperately needing more. And there's real just a fear of losing power or control or money, although there's so much need. And so I think we really have to address, like you said, at that educational level, so that medical students don't go to residency, graduate, and then enter into the practice of medicine, which becomes where money suddenly becomes part of the conversation, and worrying about who gets to deliver and care for who. And we're in a shortage. We have counties with no provider. I have patients drive 2 hours to see me. We have lots of space and opportunity for collaboration, and yet I think some of our medical associations don't play well in the sandbox together. So we have to have leadership at the top showing and leading about how we can collaborate, and non-physicians can practice at their full capacity and really be part of the solution. And so we do need to think about that, because it's holding us back in a lot of ways. And and community birth workers, doulas not having a sustainable access to livable wages and trying to come up with these payment options that work is really fundamental.
And I would totally echo everything Charlene's saying. And I think, and that Kiba was saying, I think one of the real challenges, it's going to be, maybe this is going to end up getting managed state by state, but as we try to expand, we need more health obstetric providers. And I say that providers with the small p, that, extending our workforce into lay health workers. So including doulas, including care counselors, patient navigators, and midwives. And I think that the more we can understand how we can work together successfully as a team, and really one of the things that needs to be worked on from a policy perspective, though, is how do you incorporate and how do you pay for those services? If we can get Medicaid reimbursement for doula care, breastfeeding care counselor care, patient navigators, those that's going to go an incredibly long way. We've started a breastfeeding care counselor program, and it's a really for an academic center to think outside the box. What does it look like to have lay health workers hired at our institution? What does it look like to have someone who doesn't have a high school education hired at our institution? How do you reimburse them? How do you help them document? How do you help them feel comfortable? How do you make sure they're a part of the team? Those are all questions that a lot of folks are working on, and it's really important questions because those are the kind of expansions that we need in our healthcare workforce to take care of pregnant and postpartum patients in order to really address the crisis that we're facing. And I think that's an area that you're going to see, hopefully we're going to see more legislation on, but it won't just be about solving the reimbursement issue. We also have to figure out how to incorporate these additional workers into our workforce in ways that are going to be really productive for our patients.
And quickly,
a great point. Oh, I'm sorry. I just wanted to add one additional comment, and I'm sad that Chanel is not here with us now because she brought up some interesting barriers that I think contribute to the issue that we don't incorporate all of these other birth workers into as part of the team because they're not valued, they're not reimbursed, and part of that is because of the barriers we put with some of the policies. I know that there are issues around certification and licensing of doulas, and we want to have these systems where they can be reimbursed, but at the same time, we don't want it to be a means of limiting the number of people who can access doulas or be a doula because they can't afford the certification fees or can't. We don't want that to be a system that blocks out, because I know that there were some laws and policies that came through in Georgia that tried to do that, in the breastfeeding world with making IBCLCs the only ones that could be licensed to provide breastfeeding support.
And just really quickly, I think we also need to be very realistic about the political dynamics that happen. One of our biggest oppositions in the state of trying to move and expand the team is the California Medical Association. And sometimes it's ACOG as well. And so there are these conversations that we need to also be having and pushing our colleagues and thinking about how we can redefine, again, success, and also being very realistic of what does that look like and calling out racism when it happens, and particularly when it comes through policies and recommendations through some of our professional associations. We know that the AMA is having this kind of fight right now in public when they are trying to address racial disparities, and that doesn't just stay there. We know that same fights happen in our states, and so I think, of course, what everybody said, I think we need to pay people and also make sure that we are paying people their wealth. That's one of the things that we have been fighting for with our doula bill, our doula piece, and we will be fighting for as we do the devil in the details of implementation. But I just also want to raise that there are political dynamics that are not just this opposition that we think of traditional opposition, but what also within the piece with scopes of practice and all these other things that are happening that we also need to address in order for us to have a comprehensive team. And then secondly, we need to make sure that we're thinking about how do we make sure that the pipeline to getting into these professions is open and clear and being able to have accessibility, not only for doulas, but as well as docs, midwives, all the different types of midwives, lactations, all those other things.
Thanks so much. I think we'll do one more question, then we'll give everyone some time for a break before our 2:00 session. And there's been some wonderful dialogue and questions that people have been submitting. So I'm really torn, but I actually am going to ask Dr. Vidam to bring up her question about assuring some different types of regulations. Would you like to participate? If she's not, let me say her question, which is, we regularly...
Yeah, I'm here. Sorry, I just had to find.
Well, why don't you go ahead, because your question is really on target.
Okay, sorry, I'm just sort of I was a presenter yesterday. I really appreciate all the presentations today. They're really, really brilliant. Claire, are you talking about what I said about extending the health system, or about accountability for physicians?
I'm speaking about the issue that you raised about maintaining hospital privileges and licensing renewals.
Yeah. So what I've always thought that we require even something like hand washing. Every 2 years we have to do a hand washing course. We have to do confidentiality, medical reconciliation. Many of us in maternity care have to recertify for neonatal resuscitation and CPR, even just to renew our licenses. And we have to show, regular certification. As we know, anti-racism training it's a lifelong process. We're all in a learning thing, and it's not going to be solved by going to a single 1-hour webinar, which is or training, which there are a plethora of them now, and they're of, as I think Nurbis or someone said, that they're of varying quality and bravery, I would say. And so I think there should be some standard set for who can provide those trainings. But then when there are reliable trainings, or trainings that have gone through a lot of input and careful. So for example, yesterday, Dr. Karen Scott described the Sacred Birth program. Now, it's a whole program, and it acknowledges that you can't just do one day. You have to commit as an institution to this. And we are, at the Birthplace Lab, we've done a Delphi process simply to not to create a training, but to create a quality assurance kind of a scoring system, like we had for the mapping, for the for integration across when we did our access and integration mapping study around how integrated midwives are. It's possible to measure and score the different domains that contribute to quality care. We know a lot about that now. The WHO, ACOG, ACNM, many of the organizations have worked and have agreed on the core components to advancing the both equitable and evidence-based application of interventions. So that interventions are not all bad. They're life-saving. They can be wonderful things for certain, but if they're overused, then you end up getting poor quality of care. And what's often not part of this conversation, I think, is that Black pregnant people, we know, have the highest rates of C-section. Also, and when we talk about the maternal mortality, we cannot forget that much of those complications, even Serena Williams, which was talked about yesterday, would not have happened, or would not have the risk of having some of those wouldn't happen unless you had started with surgery or started with the intervention. So, I think accountability goes beyond that. And I think what I was saying was that we need to also be accountable for the quality of interaction, the quality of experience of care, And it's possible. You can require that kind of training to get privileges or to get licensures. There just has to be what the USAID AID report called there has to be political will.
Thank you so much on that very, very important comment. Do any of the panel members want to comment back on the ways that we can integrate into the systemic approaches for incorporating this kind of training and racism focus?
I can comment briefly that I completely agree that having a 1 hour course is not going to make change. It's not going to create system change and culture change at that institution. One of the things that we're really focused on is doing training in the context of a birth equity initiative, where our institutions are going to be really working on systems change and culture change together. But I think the other thing you said was about tracking and accountability. And I think our institutions will probably be requiring this training for all of their providers as part of having privileges at their institutions. But the training will just be one part of it. For example, with the respectful care practices, it's not enough just to go to a training. Then the question is, are you putting that training into action? And then do you get feedback on that work so that you're constantly looking at the system changes and measuring to see whether culture change is happening? So looking at patient-reported experience measures, our patients will be using a QR code and getting a survey on their phones to act about respectful care, whether they felt listened to, whether they've received respectful care during their labor and delivery admission. And then those reports will go directly back to hospitals to share with providers and nurses. So it's really active feedback. So it's doing training, but then doing it in the context of other systems changes and then ongoing feedback. And I think that kind of work potentially may be important to really move change. And we'll be doing this over time. But I think about really putting the focus to really help hospitals, providers, nurses, and clinical teams figure out what they need to do better. And we have to get started. I think that's the other thing. And we have to get started on putting these strategies into action. Otherwise, so much of this is just a lot of hospitals talking. And I think that we really have to go beyond doing a few trainings and really make sure that we're moving to change.
So on that note, I will end the session. Again, what gets measured gets done. And you all have pointed out the importance of documentation, telling the story in a lot of different kinds of ways to be able to advance this agenda. So I'd like to invite everyone for a break and request that we all come back promptly at 2:00 for another fabulous session. Thank you so much to everyone.